I apologize. I'm so silly. I forgot to press record. So I just started recording now. So for everybody watching this after the fact, I apologize. We're just about 2 minutes in. I apologize. I'll repeat myself just really quickly. So I apologize. Welcome everybody to the Management Reasoning VMR. Anybody who hasn't met me yet, I'm Alex, proud CP Solvers team member, current chief resident at Northwell Health at the North Shore and LIJ campuses of the Zucker School of Medicine. I'm here with my partner in crime, David.
Hello, everyone. I'm David Solantes from Madrid, Spain, and I'm a third year internal medicine resident. So happy to be here with Alex. So we'll do a management VMR on diabetes after the one that Jess and Resma did. And Alexa is going to bring the goals that we have for this case.
So building on the session that Jazz and Reshma led last time, they talked last time a little bit about the way that we manage the mostly type 2 diabetes, what the advantages and and disadvantages of several medications are. This time, we're going to talk a little bit about taking even a further step back, how we diagnose diabetes and whom we screen for diabetes and whom we really want to screen and make that diagnosis. And then David's going to take us through case 2.
And well, we'll review with second case how to identify the different types of diabetes mellitus and which tests are appropriate for patients with diabetes and that don't follow the classical patterns. And after that, Alex is going to the last part of the session.
Yeah, and if time allows, we'll talk a little bit about the advantages and disadvantages of different glycemic targets for patients with diabetes. So without further ado, just before we jump into the first case, you guys may remember from last session that there are effectively 3 tests that we use to make a diagnosis of diabetes mellitus. Those 3 tests, if you remember from last time, are from your from learning on the wards or in your clinical rotations, are a hemoglobin A1C, an oral glucose tolerance test, or a fasting plasma glucose. And sometimes even a random plasma glucose if in the right clinical context of symptoms of diabetes can be used to make a diagnosis of diabetes too. And then what we'll talk a little bit about today is which patients we should screen for diabetes, even patients who don't have symptoms that suggest diabetes, or if there are any patients on the outpatient side whose clinical risk factors would suggest that we really need to screen to look for diabetes mellitus in those patients. And we're going to illustrate that with case 1. So Amanda, do you mind showing case 1 to everybody? Perfect. So what I'll do what we're gonna do for case 1 is let you guys take a second to read it on the whiteboard, and then analogous to what we've done in some of the other management reasoning sessions, I'm going to give you guys about 5 to 6 minutes in a breakout room. And then we'll come back and discuss all the points together. And totally okay if not everybody had a chance to read them all just now. I will send them out to everybody too. So the breakout room should all be open to everybody.
Like,
Hi.
All right, everybody, welcome back. I hope that you guys had a good discussion in the breakout rooms. And I apologize. I know jumping in and jumping out of the breakout rooms is never totally gracious. Always in the middle of a good conversation, hopefully. So maybe can I ask somebody in the first group, which I think was Kiara's group, anybody have any thoughts as to the first question for case one as to whether or not this patient should be screened for diabetes?
yeah, we have some thoughts. Actually, we're not completely sure, but we think that if he's a male less than 40 years old and he have either symptoms or he has obesity or any other risk factors, it's worth it screening.
Great.
Um, also, Landu mentioned that if he's under 35 and he's from Asia, it also there and he has symptoms, it also worth it to screen it.
Awesome, Kiara. So I think that you mentioned a lot of really great things in your discussion there. So you mentioned how this patient um the fact that the patient's Asian American, that might alter your risk factors. And that you also talked about the weight as a reason to screen or not to screen for certain patients. And I like how you also mentioned looking for symptoms that suggest diabetes. So looking at whether the patient has. So what are some of those symptoms that you were thinking about?
The common ones: polydipsia, polyuria, polyphagia.
Perfect. Awesome. Anybody? So how about anybody in room 2 or room 3? Did you guys mention anything similar, anything different? Room 2, I know, was Hans's group, and I think David jumped in there. And room 3, I think might have had Masa and Julia. How about a
No,
room?
that's exactly what we thought though. Like, since this patient is Asian American, then they would need extras. Like, you would add a risk factor, so they would need screening at a younger age.
Perfect.
Yeah.
And even just to add a tiny bit of more information. So the in terms of who we screen for diabetes, the guidelines are actually a little bit contentious. So the guidelines from at least where I practice, which is in New York, here in the US, the guidelines from the USPSTF and the American Diabetes Association actually differ a little bit with one another. So whereas the USPSTF would recommend that for patients who are older than 35, we screen for patients who suffer from being overweight or from having obesity, which basically means having a BMI that's greater than 25. And for Asian Americans, like many of you guys said, they recommend having a slightly lower cutoff, so a BMI of greater than or equal to 23 as opposed to 25. In contrast to that, the American Diabetes Association recommends screening for patients, all patients who are older than 45. So regardless of whether or not they have one of those additional risk factors like obesity. And then for patients who are younger than 45, their screening recommendations still are a little bit more liberal, like screening if the patient has a history of gestational diabetes, a family history of diabetes, history of known cardiovascular disease like low HDL, PCOS, or if they take medications like glucocorticoids that I know David will discuss a little bit later, that might predispose them to developing diabetes. So for this patient who's 40 years old and Asian American, we don't exactly know this patient's weight, so it's hard to say for sure whether or not they would be recommended for screening by the USPSTF. But by the American Diabetes Association, this patient's younger than 45, but because this patient has a risk factor of being Asian American, they probably would recommend that we screen this patient for diabetes. So given all that information, I'd love to know what anybody's thoughts were about question B. So maybe anybody from room 2, which was the room that Hans and David were in, any thoughts about questions B and C, what some of the advantages and disadvantages of different screening tests are, and which one you might want to implement for this patient.
Okay. The screening tests, I'm not sure which one is the most appropriate, but we can look at what they do measure. A1C measures the glycosylation of red blood cells, and hence it depends on the lifetime of the red blood cells. And on our last meeting, we saw that we can have a normal A1C on the background of some hematologic condition like hemolysis, so that we don't really see the diabetes at that point, and yet we do have a very high fasting blood glucose. So I think that when we notice a high A1C, we might, or the other way around, when we notice a high blood glucose, whether it's random or fasting, and that can be done in the office quickly, a fasting blood glucose or a random, then we can go ahead with the A1C. And if all those tests are pointing towards diabetes, then I would consider the diagnosis strongly under the circumstances of, yes, the entire patient. And I was made to think about a holistic approach where we look at everything in the patient: family history, his social history, including his job, whether he is physically active, his BMI, etc. So none of the tests is absolute. We have to look at all of them.
Hans, thank you so much. I noticed you mentioned the hemoglobin A1C, and I like how you brought back some of the pearls from last week's VMR about when hemoglobin A1C may not be so accurate, that we think about it as being an assessment of the person's glucose control over the course of the lifetime of the red blood cell, which is typically about 3 months. But like you said, and like we discussed last week, if somebody has a hemolytic disorder, if somebody has the disorder of chronic kidney disease, then that red blood cell is not going to last as long as we typically would expect. In some cases longer, in some cases shorter. So the thresholds that we would have for diagnosing diabetes would have to be, wouldn't be the same. It wouldn't be that threshold of 6.5 if the red blood cell is not lasting as long and isn't able to pick up as much glucose over the course of that shorter period of time, since it's not quite 3 months. So that's fantastic. So apart from the hemoglobin A1C, I know last week we also mentioned fasting plasma glucose, and we also mentioned an oral glucose tolerance test. Can anybody think of, I don't know if you talked about this in your group, but any instance when you tend to lean on the oral glucose tolerance test as opposed to the hemoglobin A1C, which maybe you see a little bit more commonly in practice? Is there any patient population that usually is tested for diabetes with an oral glucose tolerance test? Perfect. So Lon mentioned in the chat, so patients who are pregnant, and Hans is mentioning also pregnant patients that get tested by an oral glucose tolerance test. Any thoughts? It's totally okay if nobody knows just yet, but any thoughts as to why that might be? Why we might lean on an oral glucose tolerance test in those individuals as opposed to a hemoglobin A1C?
I think it's faster to answer with Mike. I believe that due to a hormone in the blood of pregnant women, they are naturally a little bit more high in glucose. That is to provide the growing child with nutrients, which needs, of course, glucose and many other things.
Perfect. So I really like those points, Hans, that the over the course of pregnancy, that because of hormonal changes, that pregnant patients are prone to becoming more hyperglycemic, and that can even happen over, like you're mentioning, over the course of just a couple of weeks or a couple of months, during the course of the pregnancy. Yusuf is mentioning in the chat, maybe it's a little bit more sensitive. I would agree. So basically, if you have a patient who over the course of pregnancy is developing progressively less glycemic control because of hormonal changes, it may not be quite 3 months of time where that patient's glucose control is changing. So when we typically measure hemoglobin A1C, like Hans was saying before, the hemoglobin A1C is assessing how that glucose control was over the past 90 days, over the past 3 months. But if these hormonal changes have happened so much more recently, the hemoglobin A1C might not quite assess for us how that how this glucose control has changed just over the past like couple weeks or even just the past month or so. So like Yusuf said, the oral glucose tolerance test is going to be a lot more sensitive in this instance because it can assess for us those even minute-to-minute changes in body glycemic control. But then to some of the points that we were making before about advantages and disadvantages of these tests, if you have somebody who then is really sick, if somebody has sepsis, or if somebody is taking a medication that's altering their glucose control, if we just test for diabetes with an oral glucose tolerance test, cortisol, that kinds of thing, excellent. So if we test for diabetes with an oral glucose tolerance test or with a fasting plasma glucose in somebody who's in an acute state of stress, because it's so much more sensitive, because it's sensitive to those minute-to-minute changes in how your body is processing that glucose, we may inadvertently diagnose diabetes in somebody who is just in a stress state. So I know we talked a lot last week about some of the disadvantages of the hemoglobin A1C, and like Hans mentioned before, hemolysis or inappropriate or different control of those red blood cells. If you have a predisposition to anemia, or if you have polycythemia vera, the measurement of the hemoglobin A1C would be altered. But similarly, the fasting plasma glucose and the oral glucose tolerance tests also are susceptible to minute-to-minute changes in the body's stress reaction. So coming back to that question B, I think what you guys will see most commonly in your clinical practice is that your patients typically are screened with a hemoglobin A1C, the outside of conditions like pregnancy where you want to account for those week-to-week changes in glucose control. So I think that brings us to question D. So if we have a hemoglobin A1C in this patient that's noted to be about 6.5 on a one-time measurement, would we say that this patient has a final diagnosis of diabetes? Would we want to recognizing that the typical cutoff of hemoglobin A1C for diagnosing diabetes is about 6.5? Would we say that hemoglobin A1C of 6.5 gives us unequivocally a diagnosis of diabetes for this patient? Would we want to confirm that for another test? Maybe coming back to group one in Chiara's group, what did you guys talk about? What did you guys think for this patient? Did you want to confirm a diagnosis of diabetes? Did you think that the A1C confirmed that, or did you want to get another test? What did you guys think?
Well, we honestly, to be honest, didn't get to the last question because
no worries.
We took more time for the first ones. But if I had to answer it now, then I would say I can make the diagnosis already, just based on the cutoffs that I know from the guidelines. It's equal to or more than 6.5, so I would say this is sufficient.
So I really like the points you're making, Leah, and I know Amanda's saying something similar in the chat, that you're accustomed to thinking that A1C level of greater than or equal to 6.5 gives you a diagnosis of diabetes typically. I also like the point that Hans is making in the chat, though, that technically the guidelines would tell us that we would want to repeat, and Mas is saying the same thing, that typically the guidelines would tell us that if we have a hemoglobin A1C that measures 6.5, or if we have a one-time fasting plasma glucose that measures 126 or higher, that technically we would want to confirm that with one other test to make sure that we have a diagnosis of diabetes. And I know that some other comments that are made in the chat about making recommendations about lifestyle modifications and metformin, absolutely those are correct too. And those are recommendations that can be made both in the context of pre-diabetes, so a patient who doesn't quite yet have the final diagnosis of diabetes, or in the context of a patient who does carry that final diagnosis. But the way I've explained this in the past to some of my learners is that any test that you get, whether it's a hemoglobin A1C, a morning cortisol, or a fasting plasma glucose, or an LDL, if you measure that one time, if you were to measure it in, say, my left arm, or if you were to measure it in my right arm, it would be rare for you to get the exact same number on those two tests. So if we have a patient who's typical hemoglobin A1C, if the correct number for that person probably is somewhere around 6.4. If we were to measure it one time, maybe we would get a number of about 6.5 or 6.6. And then maybe a couple days later, if we were to measure that, even though that person's physiology hasn't changed, maybe that hemoglobin A1C, if we measured it that time, it would be 6.3 or 6.2, somewhere just below where their hemoglobin A1C typically lives. So I think for that reason, technically the recommendations from some national societies are that we confirm this diagnosis with another screening test. So either with the same test that was abnormal, you repeat that test just a couple days later, or on the same blood draw, if you got a hemoglobin A1C and if you also got a fasting plasma glucose, if that hemoglobin A1C was above 6.5, and that if that fasting plasma glucose was greater than 125, 126 or higher, then you could say definitively, yes, this patient has a diagnosis of diabetes. And Amanda's right. So the 5.7 and above typically gives us a diagnosis of prediabetes. So Leah is saying always test again. Not necessarily. So if you have a patient who has a hemoglobin A1C and a fasting plasma glucose that both fall in that range of diabetes on that same blood draw, then you don't have to test it again. So you can say that you have a confirmatory test because you have those two tests from that same blood draw that both give you a diagnosis of diabetes. And then and like Yusuf is saying in the chat, whether or not we confirm a diagnosis of diabetes doesn't necessarily change how we're treating this patient in clinical practice right away. Because oftentimes, even if a patient has a diagnosis of diabetes, or if they have if we think that they may fall in that pre-diabetic range, we still might recommend changing their lifestyle or potentially intervening with metformin. I hope that answers your question, Leah. What other questions do you have?
I guess so. Thank you for the explanation. So just for me to confirm, so if it's borderline, then it would make sense. You wouldn't just make it for one value to test again. But if it's really high, let's say the patient has a really high ABH1C, would you say, is there a cutoff that's high enough for me? I don't need to test again. It's unlikely that this was just a one-time thing. Or would you always test again?
So maybe just one point of clarification. So I guess what I would say is that and Yusuf is making some really strong points in the chat about how the whether or not you have this bona fide diagnosis of diabetes in many cases is not changing how you treat that patient. But what may change is if you give that person that final diagnosis in the chart in terms of potentially changes to the things that we need to screen for. So like whether or not we would recommend they go for an ophthalmology evaluation, or if they need an annual foot exam with us in the office, those things may change whether or not you list the final diagnosis of diabetes in the chart, and potentially changes to their their insurance status and things like that would change based upon whether or not we list this final diagnosis in their chart. But some of those changes as to how we treat the person, how we recommend that they modify components of their lifestyle, like Yusuf is very, very correctly pointing out, don't necessarily change. Coming back to your question, Leah. So if we have a patient who has is coming to us with symptoms of polyuria, polydipsia, polyphagia, and even if they have eaten that day, if we get a blood glucose level that's above 200, so even if it's not fasting, if it's a random plasma glucose that's accompanied by some of those symptoms, then we can say beyond the shadow of a doubt, this patient carries a diagnosis of diabetes, and we can list that diagnosis in their chart. So not quite a cutoff for the A1C, but for a random plasma glucose associated with symptoms. Okay, if we jump into some poll questions to reinforce some of these things. All right, Amanda, can I ask you to show us poll question 1?
Sorry. What do you ask?
Perfect. So if everybody can see on the screen, we have poll question 1. And then I'll ask if you guys can put into the chat what you think the right answer is. So maybe take a second, read it on the whiteboard, and then throw what you think the right answer is into the chat, and we can chat about it together. Awesome. So Leah keyed us up for this question perfectly. So if we have a patient who has symptoms of that would suggest diabetes, polyuria, polydipsia, polyphagia, and if they have a random plasma glucose that's above 200, we don't need additional testing to confirm a diagnosis of diabetes. We can say without a shadow of a doubt that that person has diabetes. Excellent. All right, Amanda, can you show us question 2? I'll throw this into the chat too, just in case it's easier. All right, so a little bit of contention for this question, which I always like. So just for anybody who didn't get a chance to read it. So basically we had a 62-year-old person who on a screening visit, who on a health maintenance visit had a screening A1C that was measured at 6.7. And we asked, and we said that his fasting plasma glucose on that same blood test measured less than 125, 118. And then we asked what the best next step in management is. And I see some people said initiate metformin, some said repeat A1Cs, some said repeat fasting plasma glucose. So and this is, I think, where the art of medicine comes in a little bit. There isn't exactly one right or wrong answer. And like some people, I know Yusuf in particular pointed out in the chat before, it certainly wouldn't be wrong to give this patient metformin therapy or to make very strong dietary and lifestyle recommendations, recognizing that even if this person doesn't have a bona fide diagnosis of type 2 diabetes mellitus, that they very well may have a diagnosis. They probably then would have a diagnosis of pre-diabetes, and still we would make those same dietary and lifestyle recommendations, and metformin would also potentially be indicated depending on the patient's goals of care to potentially prevent the development of type 2 diabetes. So I think metformin would not be wrong. An answer also that I was thinking that we could do here is if we repeated a hemoglobin A1C, even if it's within those 3 months, it might tell us about whether or not that hemoglobin A1C measurement of that was above 6.5 was consistent with a diagnosis of diabetes for this patient, because we do have 2 inconsistent tests. Typically, the recommendation, if you want to confirm a diagnosis of diabetes, would be to repeat the test that was abnormal, which in this case was the hemoglobin A1C. Awesome job, guys. All right, David, you want to get started on case 2?
Perfect. So thank you very much, Alex. We go now to case 2. Please, Amanda, if you can share it as I read it. This is a 44-year-old male who was diagnosed with type 2 diabetes at the age of 40, who presented to the emergency room with polydipsia, polyuria, and weight loss. His glucose was 840. He had acidosis with a pH of 7.25 and ketonuria, and no trigger was identified. A1C was 13%, and after the DKA episode resolved during his first outpatient clinic visit, he denied previous comorbidities except for hypertension. In his family, 2 generations were affected by diabetes mellitus, and the exome was just remarkable for a BMI of 34 and cervical acanthosis nigricans. So for the sake of time, I would ask you if you can share your thoughts of 2 questions here. Which type of diabetes do you think this patient has? I'll while you're thinking, I can give you some options. Do you think this patient has type 1A diabetes, type 1B, type 2, or LADA, or any other type? I'm just saying that he might have a mixed type. Why are you taking this one, Hans? Can you explain?
Type 1 diabetes is loss of insulin production in the pancreas due to an autoimmune disease. It usually occurs very early in life or in younger patients, but I wouldn't be too surprised to see it happen in somebody with type 2 diabetes. On the other hand, if he has the type 2 diabetes at an early age, the pancreas might simply get burned out, and again, not enough insulin. And that could explain why his blood glucose gets out of range, why he developed all the symptoms, and the weight loss. That is really something concerning here. It is what we want, but it is unintentional. And I would do a keto body in the blood and in the urine.
Okay, so does anyone think that this patient has type 2 diabetes? You can share your thoughts here, or type in the chat what you think. So while you're thinking of it, I'll review shortly the types of diabetes. Okay, so we know there's type 1 diabetes, which is about 5-10% of patients with diabetes, and this is due to the destruction of pancreatic beta cells, and there are different subtypes in the type 1. Type 1A is autoimmune, and we detect typically autoantibodies, which could be islet cell antibodies, anti-GAD65, anti-insulin, anti-zinc transporter, anti-tyrosine phosphatase. There's after that there's type 1B, which is idiopathic, and we usually don't detect autoantibodies in there. And there's also LADA diabetes, which is latent adult autoimmune diabetes, which is typically are typically patients that are diagnosed with diabetes after 35 years old, and it is also autoimmune, and we can detect autoantibodies in this type, but it doesn't require insulin at diagnosis, and typically only require insulin after 6 months of diagnosis. There's also in here autoimmune destructions of beta cells, but is slowly progressing, and so there's no such insulin dependence in the beginning. Then there's type 2 diabetes, that is around 90% of patients with diabetes, that in which pathogeny there are two features: one, insulin resistance, and also a partial insulin deficiency. It's really associated with obesity, but there's also high genetic predisposition, even more than in type 1. And truth is, we don't know if there's not some features of autoimmunity there, because it seems that there's some T-cell mediated autoimmunity in the pathogeny of type 2 diabetes. Type 2 diabetes can present with DKA in the context of severe stressors such as myocardial infarction, major trauma, or sepsis, but also in the absence of a clinically apparent stressor in some phenotypes of type 2 diabetes that are called ketosis-prone diabetes, which we'll talk a little bit more now. And there are also other types of diabetes, including, as Harry said, the MODI subtype, that is maturity onset diabetes of the young, which is an hereditary autosomal dominant defect in genes that regulate the beta cell function. And there are also genetic or other monogenic defects in a subtype called neonatal diabetes. And there are also many other conditions associated with diabetes, including drugs such as steroids, such as Alex told before, but also thiazides, protease inhibitors. There are also pancreatic diseases, including pancreatitis and pancreatectomy, malignancies, or hemochromatosis. There are endocrinopathies such as Cushing, acromegaly, hyperthyroidism, all of these which go with an increase in regulatory hormones. There are also some atypical infections, including MAMS or Coxsackie or CMV, and other autoimmune diabetes related to stiff person syndrome or insulin receptor antibodies. And there are also genetic syndromes such as Down or Turner or Prader-Willi that are associated with diabetes. So, and there are, we have reviewed like the different types, but in this case, there is a 44-year-old male which with obesity and family history of diabetes and cervical acanthosis nigricans. What do you think is more concerning for in this case? There is saying type 1 because of the age and the family history. Any other suggestion for this case? Okay, so it seems to be Jasmine is saying that type 2 diabetes is more consistent with this profile. So it seems to be features of type 1 and type 2 diabetes in this case, but the acanthosis nigricans, which suggest insulin resistance and the age of presentation seems to be, and the obesity seems to be concordant with type 2 diabetes. But the fact that make us thinking in type 1 is the presentation with DKA. But as I've said, there are a subset of patients with type 2 diabetes that can present with ketosis. No? These are the so-called ketosis-prone syndromes, which happens because in all patients with diabetes, with type 2 diabetes, there is a mix of insulin resistance and beta cell dysfunction. And they combine in different ways in different patients. So there are some patients that have more beta cell dysfunction and that can present with DKA. As I said, even in the context of a stressor or not, just an unprovoked DKA. So I'm sharing just for a moment my screen to show you a different way to classify the diabetes. Can you see that?
Yeah.
Okay. Perfect. So we are used to the ADA classification of diabetes, but this classification doesn't reflect the clinical heterogeneity of patients with diabetes. And the concept that it seems to be an early beta cell dysfunction in different types of diabetes, not only in type 1. The AB system, which is designed to understand the ketosis prone diabetes, divides the types of diabetes in according to two questions. If they have autoantibodies, which is A, and the presence of or absence of beta cell function, which is beta. In this way, we can classify the ketosis prone diabetes in 4 types. A plus beta negative, which is patients that have autoantibodies but don't have beta cell function, and this could be very similar to what we understand for type 1A, autoimmune diabetes. Patients that have autoantibodies but also have beta cell function, at least initially, and which would be compatible with LADA, that are patients that initially have preserved beta cell function that slowly progress to the dependence of insulin. And there are also patients who don't have who doesn't have autoantibodies, but who doesn't have beta cell function, which we told is the type 1B, which is idiopathic. And most patients with ketosis prone syndromes are in this bucket. These patients don't have antibodies, but have a beta cell function preserved. This is in this bucket we could feature the type 2 diabetes patients, and also patients with monogenic defects such as the MODY ones. When I show you this table, what do you think? In which bucket do you think we are with the patient of the case? I'll share my screen. And Amanda, if you can share the screen. So the patient didn't have was a patient with 44-year-old and a BMI of 34, which is obesity, and with a family history of diabetes and an episode of DKA. This could be type 2 diabetes with ketosis, ketosis prone syndrome, or also LADA, depending on if he has antibodies or not. And which test would you ask for in this patient? I'll pose the question here. PSA in antibody and C-type. Okay. Perfect. Okay. Do you think, okay, GAD65 and islet cell antibodies is saying Julia, and these are two of the most common autoantibodies in patients with diabetes. Perfect. So these are the correct answers. So we don't know for now if this patient has type 2 diabetes or could have LADA. but the presence of autoantibodies and the presence of or absence of beta cell function could point toward one bucket or other bucket. What I like to tell you that there is a spectrum in the pathophysiology of diabetes. The beta cell function exists in a continuum. There are patients with type 2 diabetes that have a beta cell function very poor even at the start, but it could be reversible. And there are patients that are more prone to the type 1 bucket that don't have autoantibodies, and this has implications in the prognosis of the diabetes, but it's not so direct to make the classification in different buckets in type 1 and type 2, because there are more profiles that doesn't adjust to those that more simplistic classification. I wanted to ask you for another thing. Would you do a genetic testing in this patient? And she's saying yes because of family history, and yes is saying that we can test the HLA because it's associated. Yeah, both type 1 and type 2 are associated with different HLAs, but they are not usually tested in the clinical setting. What is testing in some cases are the genetic testing for monogenic diabetes, and this is recommended in patients with multi-generational family history of diabetes, which would be at least 3 generations or history in one patient, in one parent, and at least another first degree relative, and with features of monogenic diabetes, which is diabetes in the absence of obesity, and in adolescents with presumed type 2 diabetes. In this case, the presence of obesity and the features of well, its family history could be confusing, but the other features such as the acanthosis nigricans that points toward insulin resistance doesn't go too well with the MODY or the monogenic diabetes. So I think probably in this case we shouldn't measure the genetic testing, and with the autoantibodies and the C-peptide would be fine. If you can, if you have any question in this of this case, or regarding to autoantibodies types and genetic testing, you can unmute or share your thoughts in the chat.
Awesome, David. I know we're a little bit over time, so I think we'll hold off until next time about the discussion of glycemic targets. And thanks so much, everybody, for your participation. I think maybe for Mohammed, is it okay if we leave the teaching points here and we'll post them up on the whiteboard afterwards? Since we're a little bit over time. Thank you, Hans, and thank you everybody else for your participation. Any questions? What questions do you guys all have as we close out for the day? Thanks, everybody.
Thank you so much, everyone, for being here and for your participation and how you learn some things on this topic. So see you the next week on Friday or on Monday VMR or tomorrow in the student VMR if you want.
Thanks so much, everybody.